You know that sound? That awful crack. Maybe it was you, maybe it was a friend. A broken bone. It's something we all kind of dread. But the really amazing part is what comes next. How do surgeons take what is essentially a pile of shattered bone fragments and turn it back into a working arm or leg? Well, that's exactly what we're going to break down in this explainer.
Okay, right off the bat, we need to get one thing straight, and this quote says it all. The goal here isn't just to make the x-ray look pretty again. No, the real goal, the principle that guides every single decision a surgeon makes, is getting you back to your life. You know, being able to tie your own shoes, text your friends, swing a golf club, whatever it is you do. It's all about restoring function. So here's our game plan. We'll start with the moment a bone breaks. Then we'll look at the two different and amazing ways our bodies can heal. We'll get into the engineering side of things, how a surgeon makes their choice, what the road to recovery looks like, and yeah, what happens when things don't go according to plan.
All right, so a bone breaks. But you know, it's so much more than just a simple crack. Every single fracture actually tells a story, almost like a crime scene for a detective. Was the bone crushed into a bunch of little pieces? We call that a comminuted fracture. Or was it pulled apart in a clean line, a transverse break? Maybe it got twisted, leaving a spiral pattern. Understanding that story is the very first step in figuring out how to write the ending.
Now, this is where things get really, really cool. Get this. Your body has two completely different fundamental ways to heal a bone. And this isn't some accident, it's an incredible built-in biological blueprint. And the surgeon's job? Well, it's not actually to heal the bone themselves. They're more like a director, creating the perfect mechanical environment to encourage one of these two natural pathways to take over.
Let's break down those two paths. Think of primary healing like welding. You need the two pieces of bone clamped together perfectly with absolutely zero movement between them. When it's like that, your body cells can just come in and build new bone directly across that tiny gap. Now, secondary healing, that's more like using biological spackle. This happens when there's a little bit of wiggle room. That bit of motion is actually a signal. It tells the body, hey, we need to build a scaffold here. That scaffold is called a callus, and it bridges the gap and then hardens into brand new bone. So what's the one thing that decides which path the body takes? Simple, the amount of motion.
And that spackle method is a fascinating process. It happens in four main stages. First, for about a week, you get inflammation. Think of it as a specialized blood clot that kicks the whole process off. Then, over the next few weeks, the body builds what's called a soft callus, this flexible biological scaffolding. After that, over the next 3 to 4 months, that scaffold hardens up into a hard callus, locking the pieces together. And the final stage, which can take months or even years, is remodeling. Your body becomes a master sculptor, slowly replacing that temporary bone with super strong permanent bone until it's back to its original shape. Just an incredible feat of self-repair. So if the body has these two options, welding or spackling, how does a surgeon choose one? Well, this brings us to the engineer's contribution. This is where the biology meets pure mechanics. The surgeon's choice comes down to one single factor, the level of stability they create with all that hardware. It's a whole spectrum of stability, and they get to decide exactly where on that spectrum the fracture is going to live. On one end of that spectrum, you've got absolute stability, and it's exactly what it sounds like. The surgeon locks those bone fragments down so tightly that there is zero motion between them, even when you start moving. When things are that rigid, the body's basically forced down one path. It has no other choice but to do that direct bone-to-bone welding process we just talked about. And the tools for this job, they're all about one thing: compression. You've got things like lag screws and compression plates that are literally designed to squeeze the bone pieces together, just squishing them into place to stop any movement. And check out the tension band here. That's a really clever one. It's a wire setup that actually uses the pull of your own muscles to create compression at the fracture site. Every single one of these tools has the same goal: force that direct welding to happen. Now, let's swing all the way to the other end of the spectrum: relative stability. And here's the part that's kind of wild. It turns out that a little bit of movement, I'm talking tiny, controlled micromotion, isn't just okay, it's actually good. In fact, it's exactly what the body is looking for. That little bit of strain is the signal. It's the green light that tells the body, hey, start building that callus. It's the trigger for that whole spackle type of healing. So naturally, the hardware for this looks totally different. Things like these K-wires or bridge plates, they function much more like an internal splint. Their job isn't to crush the bone ends together. No, instead they just hold everything in the right position, the right length, the right alignment, while bridging over the fracture. And that's what allows for that perfect amount of micromotion needed to kickstart a big, healthy callus. Okay, let's bring this all together because here's the most important takeaway. The surgeon is making a very conscious, very deliberate choice. They look at the type of break, where it is, what you need, and then they pick a tool specifically to create either absolute or relative stability. They are masterfully directing your body down one of those two biological healing pathways. It is 100% a calculated decision. And this table just lays it all out perfectly, right? If you're in a cast or you get one of those nails put down the middle of your bone, that's providing relative stability. The body's going to form a callus through secondary healing. But if the surgeon uses lag screws or a tension band, that's creating absolute stability, forcing the bone into that direct primary healing. You can really see how the tool dictates the biology. All right, time for a little thought experiment that might mess with your head a bit. Picture a bone that's perfectly straight, and you have a metal plate that's also perfectly straight. So why in the world would a surgeon intentionally bend that plate so it bows away from the bone before they attach it? I mean, that sounds completely backwards, doesn't it? Well, it turns out to be an absolutely genius biomechanical trick. See, a bone has that hard outer shell, the cortex. If you just screw a flat plate onto a fracture, as you tighten the screws, it can accidentally act like a hinge and pry open a tiny gap on the opposite side. That little gap is a huge weak spot where the whole thing could fail. But by pre-bending the plate slightly, when the surgeon tightens those screws, it forces the entire fracture surface to squeeze together, especially that far side. It's an incredibly clever move to guarantee rock-solid stability. So cool. Okay, so the surgery's done, the hardware's in place, but we're not even close to being finished. Now, the patient's role really begins. The post-op period is every bit as critical as the surgery itself. This is where physical therapy and your own hard work turn that healed bone back into a limb that actually does what you want it to do. And that recovery process isn't just a random set of exercises. It is perfectly choreographed to match the biological stages of healing we just talked about. Right at the beginning, during that inflammation phase, it's all about getting the swelling down. Then, as that soft callus starts to form, you can begin some gentle, protected movement. And once the hard callus is in place and things are stable, that's when the real strengthening begins, helping the bone remodel and get back to 100%. Every single step has a purpose. You know, this is such a massive change from how things used to be done. For decades, the thinking was just lock it down, don't move for any reason. And sure, the bone might have healed, but people were often left with incredibly stiff, almost useless joints. What we know now is that early controlled motion is basically a form of medicine. As long as that fixation is stable, getting things moving prevents stiffness, the #1 complication, and it actually helps you heal better and faster. But that delicate dance between biology and engineering, well, sometimes the partners get out of sync. And even with the absolute best techniques and surgeons, sometimes healing fails, and that leads to complications. So what do we call it when a fracture just gives up on healing? The official term is a non-union. Basically, if 9 months have gone by and the bone still hasn't united, or if after 3 months there are 0 signs of healing on an x-ray, that's a non-union. The body's entire repair system has just stalled out. And this is really important. Not all non-unions are created equal. They fail for very different reasons. Over here on the left, you see a hypertrophic non-union. Look at that. The body is trying so hard to heal, building this massive callus that kind of looks like an elephant's foot. But there's just too much movement, so the bridge can never connect. That's a mechanical problem. Then on the right, you have atrophic non-unions. Here, the problem is biology. The bone ends have lost their blood supply. They're essentially lifeless, so the body doesn't even mount a healing response. So you see, it all comes back to those two big ideas we've been talking about, right? A hypertrophic non-union is a failure of mechanics, not enough stability. An atrophic non-union is a failure of biology, not enough blood supply. And because the problems are completely different, you can bet the treatments for each are completely different too. When you step back and really look at it, fixing a broken bone is so much more than just nuts and bolts. It isn't about overpowering the body, it's about partnering with it. It's this beautiful dance between our body's amazing, innate ability to repair itself
and our clever engineering that creates the perfect stage for that repair to happen. And that really leaves you with a big question, doesn't it? What does this incredible partnership between our own biology and our technology really tell us about the future of medicine?